Hello everyone. So we're going to do a HOLEP on a patient with bleeding. Patient was referred to me because of bleeding. Patient came from another province, and we're gonna use the CyberHo 152 watt Magneto laser from Quanta. Again, so this is the cystoscopy part. So we had to evacuate the blood clots that was present inside the bladder. So after finishing and evacuating most of the clots, we can proceed in doing the inflation of the prostate. So patient is actually post TURP. Later on, you will see one part of the prostate that has a section changes, and it's obvious because the median lobe will be a little bit flatter than the usual. So here you can see from the video that we already took out the blood clots, and yeah, and this is the part that I noticed that there are already prostatectomy changes or resection changes post TRP from this patient. The patient was actually had undergone TRP around 2011, and now is presenting with the bleeding prostate, and obviously maybe these are just some bleeding spots, and maybe it was false passage, and another doctor tried to put in a catheter. So now we continue and begin with the HOLEP. So I would mark the anterior part first. So trying to do an early apical release, marking my borders so that I will not be going into the sphincter, so I could protect the sphincter to prevent possible stress urinary incontinence post-operatively. So, so normally, even with the post PURP changes, I still try to look for my plane of the lateral lobe. So with a nudge, we are able to identify the plane between the capsule and the prostate gland. Using a little bit of mechanical push, we are able to dissect the gland away from the capsule and use and assist the dissection with the laser. So what I really and I have understood that what I like about high-powered lasers when you're doing enucleation, other than the fact that it will give you a clear plane, the dissection of the laser tells you really where to go. So now I'm dissecting the anterior part of the prostate, and with this technique, I really do incise the 12 o'clock. It's still an en bloc procedure. However, I'm more comfortable doing the 12 o'clock incision and dissecting first the anterior part. So I would like to put the prostate down first, so it would not be hanging from the anterior part of the bladder neck when I'm almost done. So again, this is the curtain that we usually look for when we're trying to dissect towards the bladder neck. So once I'm able to see the lateral, I will dissect again the lateral lobes, and yeah, so and then I will try to dissect the bladder neck away from the prostate, and the prostate away from the bladder neck, and yeah, so this is the part where I try to release the lateral lobes. It's quite obvious that there were inflammation before, because the plane it's obvious that there are nodules around the attachments of the prostate. Here in the control bleeders, usually I use the Magneto laser at its maximum power at 30 watts, and obviously it does give a good control for bleeders. Now I dissect the prostate up to the level of the bladder floor, so we can call that equator or just the horizon. So you'll be able to put in or dissect away, or I think this is my way of trying to prevent bladder neck contracture, since I already incised the bladder neck. I'll be able to prevent or have a decreased chance of causing a bladder neck after the procedure. So now I continue dissecting the prostate, the posterior lateral side, below the horizon line where I incised the bladder neck. Then once it's established, I dissect the prostate towards the middle, so releasing it completely from the lateral wall of the capsule and some part of the posterior part of the capsule in the prostate. Now we try to dissect some part of the posterior near the median lobe. However, it's obvious that there's not much of a median lobe. That's why I try to continue again towards the right lateral lobe location. So in a similar manner, I would try to deepen the incision and then give a little nudge again to be able to identify right away the capsule and dissect the prostate away from the capsule. If you notice, the laser actually is not directed towards the capsule, but very near to the junction between the capsule and the prostate. However, it's more focused nearer to that of the prostate. So yeah, so now we're dissecting the posterior lateral and trying to incise or enucleate the part from the capsule, removing the prostate gland from it. So we're already at the anterior part. We're just copying the level of what I have dissected from the left lateral lobe. So just to be sure, sometimes there would be like in this part, I think I'm just discussing with my residents on how I'm dissecting it. Okay, so just to continue, Magneto actually does a lot of good work in controlling the bleeders. So that's why you can see it's very nice here, not too much of a bleeding. So now we continue dissecting. So I use the mechanical force of the laser to be able to identify the actual plane. It helps the mechanical action of that laser helps me identify where I should go and what part should I be lasing on. So here we're still dissecting the anterior part. Usually when I get lost, I try to find the plane that has more that would be more familiar, and I can really identify what part is or has the actual plane that separates the prostate gland from the capsule. Again, here's the curtain that we are always looking for. Sometimes you feel like you can read now if you are able to see this thing, or curtain, because you are quite sure that you're already at the bladder neck. Again, similar to what I did on the other side, I incise the bladder neck up to the level of the bladder floor. Here you can see the Magneto in action again. So continue on incising or using the laser to dissect and incise the bladder neck up to the horizon or the equator. It's near the bladder floor. It's very nice that you can really control the bleeders quickly with the Magneto. Well, it's obvious that if you are in the right plane, there will be the distinction, or the space is so obvious that you can dissect it just using the laser without any mechanical or push. However, I don't really recommend too much for beginners to use plainly laser, because you might, laser is like really like hot knife on butter, so it can really incise and or cut through the tissue. So if you're if you're doing it or lasing on the wrong plane, it will be obvious that you might make a perforation in the capsule. So normally what I would do, I would just nudge a little and find where are the attachments. And once I find the attachment, I use the laser to release it from these adhesions.
Yep.
The attachment of the capsule and the prostate. So we're already at the bladder neck. I'm trying to push the prostate gland towards the middle. So dissect it so that we can narrow it with the cystoscopy. So here it's obvious that there's still a lot of adhesions and there's a small gland, not too much. So I've noticed that I'm getting too deep. That's why I try to dissect it using a little bit of blunt dissection instead of laser. I can see a nodule there, which I don't want to approach right away, so I'll try to look for a more familiar spot and incise or use the laser from there so that it's easier to identify. So here I try to move the incision a little bit shallower, because if I get too deep, I might perforate the capsule or get to another organ, which I do not like to happen. So yeah, so we use the laser to cut through. I like how high-powered homing lasers will cut through the tissue, very much more accurate or much more precise than the earlier generations of homing lasers. So it's almost similar to that of like thorium that cuts through the tissue precisely compared to the old generation of homing lasers. So here you can see I'm freeing it from the capsule, the posterior lateral part, until I'm able to reach the bladder neck. So it's very nice how the prostate gland or the prostate tissue moves away from the capsule when the laser hits it. So yeah, going back, I if you notice, it's not really the aim of the laser is not really in the middle.
but it's much nearer the prostate gland. This is to avoid, again, I think for me, would to avoid perforations that you don't really don't want to happen when you're doing the procedure. Again, so pushing the prostate towards the middle until it's a little bit stuck is left, so that I can remove the prostate. So I try to be careful, especially in the posterior part, because I might perforate it. I might go subtrigonal. So I do slow down a little bit more when I go to this area, and then be careful as much as I can to dissect the prostate away from the capsule. So we're almost there, almost able to remove the whole prostate. So just a few more attachments. It separates clearly and beautifully from the capsule, and you're in the right thing if it's separating very nicely and you can see the thing perfectly. But it's not always like this. Sometimes you would encounter dense effusions because of inflammation, or maybe something else like cancer. So sometimes it would not show as clear as this one. However, that's the reason why you have to have a good imagination as well. Yeah, you know how to dissect or how it would be applied once you have enough data. So normally it does come with experience. So there you go. We are able to remove the prostate. Just a few minutes of our time, and use the Magneto laser to control the bleeding. So usually I would make the field so the clear, so that it's easier to morsellate. So there was a view before of the sphincter area, the mucosa. It was well preserved because we did an early apical release, so we don't have a problem with that. So yeah, so we're using the Magneto to control the bleeders. It's very nice because of its pulse modulation. It's obvious that it's something like you have like your own like a 2-in-1 in this Magnetos. Like you have a thulium fiber laser, because of the wavelength, and for stones, of course, its ability to dust or make fine dust particles when you do a laser lithotripsy. So yeah, so this is the part that really what I usually ask my residents to do, is to control the bleeding. And there you go, almost done. Very nice capsule, very nice fossa. So control bleeders, and once I'm quite contented with how it looks like, I would turn on or request or change into a morsoscope, so I can start with the morsellation. But I do like to make the floor or the prostatic fossa color white,
just to to be more comfortable when doing the morsellation. So I wouldn't think too much about the bleeding, etc. So I guess we're doing a pretty good job here. So and block location. The prostate is full. It's just an incision in the hollow clock area. And then yeah. So after this, we insert the morcellator, the morsescope. We change the morsescope, leave the outer sheet, and then put in the morsescope. And for this chance, we use the Cyberblade Quanta from Quanta System. It's quite okay. I think it has its own strengths, and it does the job. So maybe not as fast as other morcellators, but it does uh, the job pretty well. So yeah, thank you for watching.